Friday the 13th, I was diagnosed with an illness that was a rare autoimmune disease, and it gave me 2 years to live, and which is quite a rapid 180-degree turn for an 18-year-old who the next day was supposed to report to UNC for his freshman year. North Carolina has the highest rate of substance use disorders to the lowest rate of available resources of any state in the country. Parents are shocked that to hear their 6th and 7th graders have access to high-potency marijuana and prescription drugs more so than they do alcohol. People can order legally off of social media, have it shipped to their house in a nondescript FedEx box, and parents would be none the wiser.
If we make it legal, then there won't be any drug dealers, but yeah, they will. They'll just move over to the harder drugs that are actually easier to conceal and smuggle because weed takes up a lot of room. Fentanyl powder and pills do not. Hello, I am B. Reeves with New Waters Recovery in Raleigh, North Carolina. Welcome to our weekly podcast, Finding New Waters. Our goal in creating Finding New Waters is to provide a resource for families to help navigate the complexities of supporting a loved one struggling with substance use or mental health. When we find ourselves in crisis due to one of these issues, most people have no idea where to turn. We hope to shed some light onto what is often the darkest hour for many families. Thank you. Welcome to the podcast, Ward Blanchard. Thank you so much for being here.
No, it's exciting always to have an opportunity to chop it up and talk shop, but it's great seeing you if it's not virtually, but it's not in person, but if I can't get you in person, virtually is just as good.
No, I hear you. Well, I luckily had the pleasure of seeing you in person about exactly a week, I guess it's almost 2 weeks ago, where we were at the Recovery Awareness Day conference Ward puts on through. So Ward is the founder of the Blanchard Institute and Blanchard and Associates, who all do many things in addition to putting on this yearly conference, which is an amazing, amazing conference. I've had the pleasure and honor to attend last few years. So I don't want to tell everybody your quick bio. Why don't you tell us what all you do, Ward?
Sure. Well, thank you for that, to be it. So I'm the founder of the Blanchard Institute, Blanchard and Associates. And, what that is, Blanchard and Associates is a private family consulting, family intervention case management practice that is been around for about 10 or so years, ever since I, sort of started in the field. However, my main focus and my main passion is with the Blanchard Institute, which is a community-based outpatient continuum, based here in Charlotte, that provides all levels of dual diagnosis, substance use disorders and mental health support on the outpatient basis that has, like I said, its basis in Charlotte with some locations in Lake Norman, and hopefully, continuing to grow to create, more resources for the North Carolina community.
Yeah. I've also had the pleasure and fortune to work with Ward and the Blanchard Institute, especially over the last 4 years. And so how did you get into this field? What's your personal story, a little background on you and how you ended up where you are?
Sure. No, thank you. Because we just, not many of us just, have a passion and a desire to be in this field from the onset. We kind of fortunately trip and stumble and find ourselves into the blessing of being in this field. And that's sort of what happened to me. I, born and raised in Eastern North Carolina. I'm a Tar Heel by blood, and always envisioned that you grow up in North Carolina and you have anywhere near sports or being in the sports, you kind of either bleed Carolina blue or state red. And I was very much into sports and North Carolina. And I was that kid that you kind of loved to hate in high school. I tell you, like I'm kind of aging myself here, but those Freddie Prinze Jr. movies where you got the homecoming king and the prom king and all that stuff that just insufferable people, that the kids that you love to sort of hate in high school. And that was sort of me in the late 90s. And then I was getting ready to head to UNC in the late 90s, actually, to play ball. And at the time, I was pretty straight edge and didn't smoke, didn't drink, didn't do anything, not only because I was scared to death of my mother. But if you got caught with any of that, you lost the ability to play sports. So I stayed away from all that in high school. And literally just a few weeks before I was supposed to report to UNC, I started to get sick. We didn't know what it was. And I remember like it was yesterday, Friday the 13th. It was just a couple weeks after I accepted Athlete of the Year for North Carolina in the late 90s and couldn't get out of bed. And Friday the 13th, I was diagnosed with an illness that was a rare autoimmune disease, and they kind of gave me 2 years to live, and which is quite a rapid 180-degree turn for an 18-year-old who the next day was supposed to report to UNC for his freshman year, and so that kind of rocked my world, and through the course of a couple of years, and a trach, an oxygen tank, about 90 operations, we put Humpty Dumpty back together again, and was very fortunate and blessed for that. And the same time, that was sort of at the height of the OxyContin push in the late 90s and early 2000s, and was sort of introduced to that as a way of managing the surgeries and the pain. And about 4 or 5 years after I survived this sort of medical trauma and medical issues that, the substance use disorders hit my life and my family's life. And, as it always does, the disease sort of took off and made my life unmanageable. But the most important thing in relation to what brought me into this field is, I was blessed and privileged to grow up in a family that had all the resources in the world. And we still couldn't find help, still couldn't find appropriate resources to not only treat my disease, but also help my family. And so I think that is one of the issues, that we were left Googling WebMD, trying to figure it out ourselves, and in and out of 28-day spin cycles, trying to figure it out ourselves, and suffered probably more consequences than we needed to, because we couldn't find the professional help within the state. And fortunately, I through that experience of trial and error, we ran into a man named Dr. Jim Tracy, who was a family consultant, case manager, does what I do now with Blanchard and Associates, that sort of took my family under his wing and directed our treatment and directed our care, and was our guide, so we didn't have to do it alone. And I got into the recovery process and healthy and stable in early 2000s, and that was out in California. He brought me into Betty Ford at the time in the early 2000s, and I followed his direction and just stayed out there. And at the time, I dedicated myself to understanding what happened to me, and what happened to my brain, what happened to my the person that I was, what this disease did to me, and what it did to my family. And so I threw myself into school, understanding of the brain, all forms of treatment. And out there in Southern California is the best of the best and the worst of the worst at that time. And I was very fortunate to have experienced men and women that took a liking to helping guide me, mentor me in my professional career, and was exposed to some tremendous opportunities and experience in my late 20s, and always wanted to take everything that I learned out there and bring it back to the state of North Carolina. And it's what I call the Fertile Crescent out there of sort of that psychology and exposure. And so I moved back to North Carolina and Charlotte in 2015. And at that time, being in the most progressive city in North Carolina, there wasn't one dual diagnosis long-term aftercare in the whole city. And so that's where we created, the Blanchard Institute, and really founded that in 2017. It's been a blessing, even through COVID and it all. It's been a blessing to be able to serve this state.
Man, I knew a little bit about your story, but I did not know about the part from Eastern North Carolina and that you were a ball player and that close to that. And thank you. It's an amazing story. I'm a old true North Carolinian. I remember I had a bumper sticker on my door that said my blood runneth Carolina blue. My parents both went to Carolina. I was unfortunately too dumb to go to Carolina, but I could still grow up a Carolina fan for sure.
Yep.
And I think, it's funny because there is that house divided, state divided, either the state or Carolina. But the older I get, the more I realize that I really just don't like Duke. I was so happy with state in the going to the Final Four this year. I mean, it was a beautiful thing. It's largely probably due to it was almost a mercy going for them because they've been so bad for so long. But in terms of personal memories, I was born in 1977, and I have no memory of Carolina winning the national championship in 1982, but I remember the aftermath and specifically having the blue sodas that came with the national. But then 1 year later, when state won with Lorenzo Charles, I remember it vividly seeing that happen. It's funny how 1 year can, when the memories really kick in. Yeah.
Those blue sodas were good. I bleed Carolina blue. I actually ended up working for the team for 5 years. And that was a way that the department sort of honored their, sort of commitment to me, even though I took a year off when I got sick. But I worked for the team with trach and an oxygen tank and all. I was sitting there behind the bench for 2005. Yeah.
Wow. I'm sure I saw you at games and didn't realize it. That's really cool. And so, yeah, as far as the Blanchard Institute, that's shocking yet not surprising, or maybe the reverse order, that being the biggest city in North Carolina, most progressive city, still didn't have what people gave lip service to, what everybody needed and wanted. But it took you to bring that to the city. So that's awesome. What have you seen, since its inception, or even since you've been in recovery and now, worked in the field? What's changed? What are you seeing that's, popping up more or less now than, say, 5 or even 10, 15 years ago?
Yeah, no, great question, because I think there's a very real and serious answer to that. I think unequivocally that the fentanyl crisis and the mental health acuity has created a scenario that more so than any other time in my career over the past 15 and 20 years, our services and just human services in general are never more in demand. And a situation, whether it's the impact of COVID and how that took an already anxious generation prior to COVID, and then put it through 2 years of an environment that impacted everybody. And then you throw fentanyl on top of that. Right now is the highest acuity that I've ever seen behavioral health and substance use disorders in our whole my whole time in the industry. And the flip side of that is, I don't think as professionals have caught up to that acuity. And I think if we look back at the information and the data, that despite all of our advancements in technology, despite all of our advancements in healthcare and our understanding of the brain, and outcomes still haven't improved very much in 40 years, despite our ability to treat this disease and understand it has improved monumentally. And that's a complex answer. It's not all about the professionals. There's social determinants of health, and there's North Carolina has the highest rate of substance use disorders to the lowest rate of available resources of any state in the country. And so that's a complex answer of why we haven't caught up. But there's certainly some responsibility on the professional community to realize that, providing, evidence-based care and really treating this disease with the reverence of how deadly it is, we've got some responsibility to understand that right now the status quo is not acceptable, and we need to do better as a profession, and our clients and families deserve it. And never more than now is that needed from our profession.
Yeah, I heard you quote that same stat at the conference a couple weeks ago, and I did not know that we the highest per capita for need with the lowest availability of resources. So that's a scary statistic. Yeah, I mean, I'm definitely, seeing what you're seeing, but also something we're seeing. I'm wondering what your take is on this. We're seeing, it's not the most common thing, but more and more where we have this, especially, but not always in the younger demographic, this THC-induced psychosis. Are you seeing much of that? And if so, how are y'all treating it? And what do you think that's all about? And can it be cured?
Yeah, no, it's again, it's a question's great question and thing to highlight. And that statistic about North Carolina actually came in 2019. I went to North Carolina Healthcare Summit, and that came from some of the there was Atrium CEO, Novant CEO, and the Chief Medical Officer of Blue Cross Blue Shield were up there having a panel discussion, and that came out on one of the informational slides, and never more prevalent than what you're talking about with the THC prevalence that we see. I think, especially in the young adult population, THC-induced psychosis and impact is one of the highest increasing demographics that we see, and it's just getting younger. I tell people that we're in a state now where it's our current society where there's no safe experimentation, is what I call it. Is gone are the days of the hippie lettuce,
right,
of 15-20% purity, or the days, as unhealthy as it was, that we drink Strawberry Boone's Farm before high school. I mean, it's as unhealthy as that was. 98-99% purity of THC, and that it's just getting younger and younger. Whereas I used to go out in the community and talk to high schools, I now go to middle schools, and talking with the kids, the parents are shocked that to hear their 6th and 7th graders have access to high potency marijuana and prescription drugs more so than they do alcohol. And so if you take that into consideration, that high potency marijuana is being consumed by younger and younger, and the impact that has on underdeveloped brains, what you get is gasoline on an already burning epidemic of, and that the conversation about legal or illegal isn't, I tell people that's a different conversation. Budweiser's legal, Percocets are legal, and that doesn't mean that it's not harmful.
Exactly. And, so is Scotch Guard and nitrous and gas and magic markers. I mean, there are plenty of things that will change the way you feel that are legal. That's you're right. The nice way to say it is that's a different conversation. But back to, aging myself again, I remember specifically being a junior or senior, 1994 in high school, when the weed, the hippie lettuce you just referenced, where it was, from Mexico, stems and seeds, made you laugh, made you hungry, made you tired, all of a sudden was this hydroponic, white stuff with blue veins in it that went from getting high and laughing to being, like a full, tripping experience. And, and I didn't like that. Fortunately when I got sober, I wasn't tempted to try that, California sober program because I didn't like weed. But to your point, though, it still somehow maintains this harmless reputation, but at the same time, we've been saying for, since Just Say No, that it's the gateway drugs. We've given lip service to it that it's bad, but the fact that it somehow still has this reputation in general. I mean, and people like us who work in this field have a different opinion, obviously, but get to drive high, that it's just completely harmless. Meanwhile, all this evidence shows, well, we've already known that's already a gateway drug, and furthermore, now it is a completely different drug altogether, which is scary.
It's very, very different. And you're right. It's very, very scary, and it's misunderstood, and it's grossly misunderstood by our healthcare system. And even though it's misunderstood, we've got a responsibility as a healthcare system to understand it, educate yourself. Like, for instance, just last week, we got a letter from a physician out in the North Carolina community that says that we should allow their patient to use the DHA gummies, the gas station gummies. And I called him to understand it. You know, I always be curious rather than judgmental. And I said, help me understand your recommendation, because that's a gas station drug that's not pharmaceutically created. You have no idea what percentage of what's in what. And that's a gas station chemical that you have no idea how it's measured, how it's done. And they said, well, she goes, I didn't even think about that. And I said, I hear you. And so this letter, I just wanted to call to collaborate with you, but I've never seen a letter from a doctor that is recommending gas station drugs. And that's where you get that, a gas station. And so it's unregulated, and she said, I didn't think about it. And I said, well, and her comment was, well, the patient was so passionate about it, I didn't want to disagree with her. And the heart of that is sort of the healthcare systems, but whether it's because of how they're paid or customer set, has gotten to where we're customer service.
Yeah.
And that's not the job of a healthcare professional. It doesn't mean that we don't pay attention to that. It doesn't mean that we don't use compassion and kindness. But when that doctor at 18 had to tell me that I had this condition and I wasn't allowed to play sports again, and I may pass away in 2 years, that was an uncomfortable conversation. And what was he supposed to do? Customer service, just so I wouldn't get upset, shoo me out the door. And so I think in general, as a whole, both in this field as behavioral health professionals, but just in the healthcare field, having those difficult conversations and being the professionals that we took an oath to do, I think we've kind of got that mixed up with customer service, and we have a responsibility to kind of check ourselves on that.
Absolutely. That, and the appalled, and I'm also even surprised to hear that, but it kind of reminded me of, you know, something our esteemed medical director, Dr. Hong, who was on the panel at the Recovery Awareness Day conference, who's unbelievable. He told us one time, you know, to always be very wary of any psychology practice that has 5 stars, because that sounds like customer service. Those are the people who are writing prescriptions for whatever people want. And it sounds like that this case is very similar. I mean, yep. But and that reminded me of something else. I remember talking to your, Judy Goodwin, whom we all love, who works with you and has for a long time. I remember she was the first one who told me about the gas station heroin. Like I think that the gas station stuff was just starting to really happen probably about 4 years ago, maybe before. But tell us what people are getting, what you were just talking about then, and what she was talking about, and the dangers of that, and what's out there, what's in it.
Yeah. So that's very actually one of the requests that we get most often is to go into middle schools now and talk about exactly that question. And so I have a sort of like an hour-long presentation that we volunteer to do, and it's called No Safe Experimentation, because of what middle schoolers and people can access at the gas stations. And so it comes into our office every week. And whether it's the synthetic marijuana, whether it's the gummies that even though you can say that it's only medical marijuana is legal in North Carolina, no, THC is in those gummies. It is unregulated and unlicensed, and they're all over, whether it's Kratom or whatever it is. It's ungoverned, unlicensed, non-evidence-based stuff that you have no idea what chemical makeup's in it, what else is in there. And you can access that free of charge. You can also access it on social media via Snapchat. And there are things that I can't even pronounce, like Kalanazepam, and that people can order legally off of social media, have it shipped to their house in a nondescript FedEx box, and parents would be none the wiser. Yeah. And so that's what our youth are engaging now. And what we do know is the earlier the introduction of substances, the overwhelming higher likelihood they develop mental health issues and substance use disorders. And so if you're listening to this podcast and you think about when you had your first substance consumption in 11, 12, 13, 16, 18, 21, whatever it is. Now imagine that being a research chemical drug or 98% wax marijuana that you're smoking and inhaling. And that has a much more profound impact on children's brains. And so we're seeing that just whether it's Kratom, whether it's the THC, just the easy access of substances. And make no mistake, the legality of marijuana is going to sweep the nation. That's about a government cost savings initiative. That's not about whether it's healthy or unhealthy, and that is going to happen. And it'll be legal and available in every state in the country, which also means that drug will be less valuable in the illegal market, and so those dealers will go to the harder drugs like fentanyl. And so it's the future. And the last where I'll land my plane is, I was talking with one of the local news people who come by to ask about the opioid overdose statistics, which are now over 100,000 or whatever, and asked me what I thought about the future. And I said, sadly, it's going to get worse before it gets better. And she said, it couldn't be. I said, oh, it will. It's going to get worse before it gets better. And that's where we are right now, especially unless our professional community decides as a whole that we're not in competition with each other, and we need to really work together with communities to really do something about this.
Yeah. That's an interesting point too. I hadn't thought about that. How, it does seem there's a foregone conclusion that marijuana will be legal, and that, I had thought about the fact that, because that's part of the argument, right? That they say, well, if we make it legal, then there won't be any drug dealers. But yeah, they will. They'll just move over to the harder drugs that are actually easier to conceal and smuggle because, weed takes up a lot of room. Fentanyl powder and pills do not.
No, it's we actually have evidence of that. I mean, it's like people also argue, well, it's a substitute for chronic pain and opiates. I said, well, that's not what the data tells us, because it's been legal in Colorado for years, and actually overdoses went up because it wasn't a substitute; it was a partner drug. Right. And so all of the statistics show that it did not substitute that. Actually, the overdoses were. When they made it legal, were some of the highest ever. And so, the data and information and just the human experience shows that we certainly need to make changes. And, we don't need to, penalize it like we do. That's not that's not what I'm saying. Mm-hmm. We certainly need to make significant adjustments with how we view it legally and that sort of thing, and the consequences that people face. But it doesn't have to be either or. Yeah. And so, yeah.
I know you do interventions, been doing them for a long time as an individual with Blanchard Associates and 12-step calls, whatever you do. But let me ask you, for families out there who are not quite maybe there, always, try to give them some resources in case they do need to go that route. But if somebody's just trying to have a conversation with a loved one, maybe with 2 or 3 other people, what advice do you give people just to try to help somebody who really needs to go to treatment or go to a meeting, whatever, just to take that first step? What do you recommend people do, just as kind of a baseline general rule?
Yeah, no, actually, if I spend the rest of my career having this same 2-minute conversation over and over again, this is what I'm really most passionate about. And actually the root of what I think some of the barriers are in helping people is how to help families and really treat this disease. Is there's this gross misunderstanding and misinformation. What I tell people, if you don't listen to anything we have to say on this podcast, listen to the next 3 minutes. Is the idea that you really have to want it to get better, have to be motivated to get better, or hit rock bottom to get better is categorically false in everything that we know. And sadly, it is communicated not only in the recovery community or the healthcare system, but even behavioral health specialists say you really have to want it to get better. And where I say that, sadly, that gives just the unbelievably wrong message. And I know it's unintentional. And I clarify this for everybody. I say, if somebody's going to live a lifetime of healthy wellness and healthy stability, yes, they're going to have to want it. They're going to have to engage. They're going to have that motivation. But in the beginning, in the first year to 18 months, absolutely not. Because what we know is most mental health conditions are a dysregulation of people's frontal cortex. And we know that all substances of abuse affect the body differently initially. We have uppers and downers. We've all heard of cocaine, speed, meth, downers like benzos, alcohol, opiates, marijuana, uppers and downers. Some people like to go fast. Some people like to go slow. Some people like them both. But in the end and in the long run, all of those chemicals, all of those substances of abuse affect the body and the brain the same way. And they shut off or severely diminish the activity in the frontal cortex. And without geeking in neuroscience, why is that so important to your question and so important to any family member or any loved one listening to this? Is because that's the part of the brain that controls who somebody is: executive functioning, rational thought, decision-making, emotional regulation, everything that makes an individual who they are, that separates us from reptiles, is not working properly. That's why the most common statement I hear from families and interventions is, I want my loved one back. I want my spouse back. I want my child back. My family called me Wardzilla. And I was in my disease. It's because the part of the brain that makes those is just not working properly. And so, and one step further is, we know those substances of abuse affect the dopamine, the motivating part of your brain. And so why would I ever tell somebody they have to be motivated consistently or have to want it, when not only is their motivation dysregulated, but the part of the brain of common sense executive is not working properly. And so to wait till they're motivated can be catastrophic. And so the message to families is, there's absolutely stuff you can do and should do to help your loved one, because 9 out of 10 of our patients, although it's voluntary treatment, that it's really compliance that we need, right? And the 12 steps have believed this and said it since the 1930s. They say, come in here and fake it until you make it.
Totally.
Yeah. Come in here and comply until you want it.
Yeah.
Right?
I mean, what you just said in a more scientific way is, we don't know what the hell we want. We don't. And it's also goes to why, it's advised to not make any big life decisions in our first year, because we still don't know what we want, even a year in, whether that's, a new relationship or a job or whatever. And then, what I tell people all the time is, we can get sober for other people and for compliance reasons, for mom, for wife, for kids, but we can only stay that way for ourselves, to your point.
Yep.
And then the other thing that you reminded me of there is, I remember I was about 4 or 5 months sober, maybe a little bit more. No, it was about 4 months sober, right before Thanksgiving. And I had gotten sober late June of 2018. And I was doing my 4-step, and I got really into it and went to town on it and wrote down all these people who had pissed me off and wronged me, and some were big, some were petty. And I was all into it. And then I just didn't touch it for weeks. And I knew that I was not doing what I was supposed to be doing, or I was sitting on it and procrastinating, sloth in 5 syllables, all that. And then I heard 3 different people over a 2-day period say the same thing, which was recovery. They said the actual form of recovery I'm in, but I won't say it for the podcast. It's not for people who want it. It's not for people who do it, or people who need it. It's for people who do it. It's for people who do it. And to your point, we can fake it till we make it. Just do it. And then the results will come if we do the work. But I hear you. You're right. People, it's like everybody's waiting on this perfect this just magic cocktail of rock bottom, right place, right time. That's all great if that happens that way. But, you know, my mom and my family, I was about probably 12 hours from a phone call to somebody like you, or an actual, at least an intervention attempt by my family. But I went, and it was not my idea. My idea, but I just thought about being a kid in church, and I was like, all right, I'm not going to leave. How can I make this go by fast? The only thing I knew was to participate. So if I picked up the hymnal singing at church, I could sit down again faster rather than just standing there. And so I just did it, you know?
Yep. I couldn't agree with you. I mean, if we really looked at this like a healthcare disease, I mean, like because that's really what I compared it to, is when I got sick at 18, and then when addiction hit my life 5 years later, the impact on my family was similar. And when I was 18, listen, I didn't want one of those surgeries, one of those 90. I wasn't motivated for any of those 90 surgeries.
Right.
You know, chemotherapy, radiation, they suck. They're inconvenient. They're costly. It's unfair. They ought to make you angry. That's all okay. And it was still the appropriate path to save my life. And actually, when I was 18, when I was diagnosed, they said, you can stay in the hospital. We can treat you with medicine for the summer, or we can give you a trach and let you go home. And I said, I'll stay in the hospital. I don't want that trach. And my parents said, no. He needs the trach because he'll die. They didn't give me the choice. I mean, and so this is a healthcare crisis.
Right.
It's not about what we want, and it's going to be uncomfortable. The only difference that we try to communicate is you shouldn't have to navigate it alone, like my family had to do initially, and the healthcare system still throws it at their feet and say, you Google WebMD and you decide your own treatment plan. That's where we at the Institute and even in Blanchard Associates have a stark polarizing opinion that this is just like any other disease. If you find the trusted professional that leads the treatment plan, prognosis is actually pretty good. It doesn't mean that it'll be perfect, but what disease is, and what serious progressive disease doesn't take 2 years to stabilize. And so I think, I mean, to what you've talked about, I think a lot of the solution is, as professionals, getting the accurate information out there, and it talked about, and not only in the healthcare system, but out there in our societal conversations, to not only give the accurate information, but also just sort of reduce the stigmas. But when we go and do continuing medical education at local large systems, I'll tell you that you get all those doctors and healthcare system in the same room, they still don't have any training on it. They have more training on diseases in the Caribbean and sub-Saharan Africa than they do on behavioral health, despite this being pandemic.
Right. It's such an irony that it gets so much lip service, but really not enough attention.
Yep.
Yeah.
No, and with your role in what you do, what do you see as sort of that barrier to entry? Because one thing I can tell you, that looking at the data, that millions of people that need treatment, still less than 10% get it, same as what it was decades ago.
Mm-hmm.
And you can't say that nobody talks about it anymore. Can't say that, because we still have a lot to do with the stigma, but the overdose crisis and the fentanyl, I mean, it's the hottest topic. So
right.
You can't say. So what do you experience as some of the barriers?
So a barrier I'll talk about in a second, but you said something about the stigma. There's sometimes I wonder, and it's overall a great thing that the stigma has largely been lifted. But I think that maybe in some ways people kind of come in, or more inclined to come in for like a tune-up, because the stigma's not there. So it's okay to admit it, but keep coming, back and forth in and out of treatment. Because before, I feel like when people finally did, then the stigma, was such a looming specter that kept them out of the shadows, so to speak. And then once they finally were, really did hit rock bottom, and then did do, and not just wanted and needed, but did it, then maybe people took it a little bit more seriously, especially in the early days of, Bill and Bob and all that. But in terms of barriers, there's a financial barrier for sure in terms of getting actual treatment, but in terms of getting help, I think that people just think that no matter what, they think that they got this. I think that's still the biggest barrier. And I would say the other biggest barrier, I think, and just from my personal life, also work, but also personal life, is people just cannot imagine life sober, being a life worth living in quote unquote fun. I think that is a huge barrier. People are terrified of that. I was.
Yeah. Yep. I think that's actually a great point. I mean, which is very understandable, and you want to be compassionate and empathetic for that. And you don't let that stop. Families shouldn't let that stop life-saving treatment. Like when I got a trach, I couldn't swim in the ocean anymore, and I'm from the Outer Banks, terrified of it. That didn't stop my family from forcing me to do it to keep me alive.
Right.
And we won't do that with this disease, because we still allow the emotional needs of the patient and the family to dictate treatment. And that doesn't mean that we don't pay attention to them, that we don't listen to them, that we're not compassionate, but you don't allow it to dictate treatment. Like I said, if I didn't want that trach, I was scared of it, but I required it to save my life.
Well, it's interesting because I think people overall, again, it's back to the lip service and understanding something intellectually versus the actual practice of it. But when people understand, because when we talk about it being a disease, I think people are happy to say that and admit that and accept that, but they're not willing to really treat it like a disease. And so when people do understand it in those terms, like if somebody has diabetes in your case with all your treatment in a tracheotomy, or with cancer and chemo and radiation, when they really understand it like that and understand that instead of having to go get chemo or radiation, all they have to do is just go to a meeting and and stay sober one day at a time, seems pretty reasonable. But somehow there's that major disconnect between the understanding of it intellectually and then really practicing it as a disease.
And you hit the nail on the head, being in my professional CEs when I'm talking to, whether it's doctors or, the one thing I say at the beginning is all of us will raise our hands that we recognize it's a disease, and we will absolutely lose it in the application of our services. And and our own therapists, they'll say, well, he doesn't want to go to sober living, or he doesn't want to go to residential, and or I told him that it would only be this length of time, and now it's this. And it's like, listen, I went in for a 3-hour surgery, and it ended up being a 12-hour surgery. And so that surgeon, he wasn't after my insurance. Like, it didn't make him a liar.
Right.
It just, when he was in there, the disease symptoms adjusted, and he had to do what he needed to do to save my life. And there's this misconception, as you put it, that we'll all raise our hands that we think it's a disease, and professionals, the professional community, when it comes to the application of our services, we will not treat it like it's a disease.
Yeah. Well, yeah. Well, I mean, you said it perfectly. I mean, the application of it is exactly right.
Yep.
Well, man, go ahead.
No, I was gonna say, like, what I do, one of the things I do, if families really, I'll show them a picture of their loved one's brain in the first 120 days of their abstinence, and how the brain is not functioning very well, and it comes back. And I said, help me here. Like, how many of you would allow somebody with this level of brain functioning to have any influence over your life or death medical treatment plan? And then to this day, no matter how defiant the family's been, I've never had somebody say, oh yeah, I'd let them. And so I'm like, then why do we allow them to dictate their own like this if you wouldn't allow them to influence yours?
Right. It's funny because I'd never thought of addiction, as being a contagious disease. Like, I understand the genetic part, but being contagious. But what you're saying, it's almost like it is contagious, in that these people, like I was, a little over 6 years ago with a compromised frontal cortex where I didn't know what I want through which causes the insane thinking of addiction. And then the family members who are becoming insane by osmosis, it's almost contagious, that the insanity this person really has because of the disease and the frontal cortex and everything we've talked about is making the loved ones make irrational decisions and insane decisions. It's wild.
No, what we know is that family members are 5 times more likely to be in the hospital. Family members of people with a progressive disease. It's not just, and this is where you can land our plane, because this is what the Institute is based in, is treating the family differently like this. It's not that we engage families, because lots of treatment centers do that, but how we engage them is the difference in understanding, what you just talked about is that, family members, it's traumatic what they go through. Meaning, when I was at the height of my substance use disorder, my mother called my house every morning at 6:30 a.m. And I thought she was being the overbearing mother that she still is. But when I went through this, and I'm alive because of her, so I can say that. And when I went through this recovery process, I found out she was just calling to see if I was alive. And at the time, that wasn't a hyperbolic reaction. It wasn't an overreaction. The state of my disease, she had valid reason to wonder every moment of every day if I was alive. And what other scenario, other than having a loved one deployed to war, and I'm not comparing war and the disease, but I'm comparing what families go through, where you have valid mortality level stress and concern day in and day out, day in. And isn't that traumatic? I mean, trauma doesn't have to be a capital T. Death by 1,000 cuts is still a death.
Totally.
And that's the same stress that my family went through when they was wondering if I was breathing upstairs 5 years before. And so that's why that chronic, constant stress. So I have family members of people with any progressive illness, whether it's substance use, mental health, or autoimmune disease. Family members are 5 times more likely to be in the hospital, which is why we are such family focused, and it's a very contagious disease, like you described, very much so.
This has been absolutely amazing, and I think we'll end it there. And Ward, I just cannot thank you enough. This has been, I've known you a little bit for about 4 years now. I feel like I really know you so much better. Thank you, thank you, thank you. That was awesome.
And I appreciate it. You can see I get passionate about it, and I can talk shop. But I really appreciate actually your general conversation about it. The questions were right on point, and just these conversations out there in the stream is how we're going to inch forward little by little. So I'm really grateful. Thank you.
Yes, sir. And that's what the whole purpose of this podcast is, just to help. If we can help one person, then we're doing our job. How do we find you in Blanchard?
Yeah, absolutely. Because that's what we want to be. Is we just want to be a behavioral health resource. And so whether we can help you at Blanchard or whether we can get you to the right resources, is find us on the Blanchard Institute online is probably the easiest, most accessible, and or give us a phone call. Our number's there, but reaching out to us online, we have at theblanchardinstitute.com can lead you toward all of our access points. Our web forms and emails go straight to everybody, and we get back to you immediately. And where I leave it is, if you're out there and you think your loved one needs help, if you are struggling yourself, if you're a loved one, family member, friend, or even a professional, we just want to be your first call and resource. Like I said, if we can't help you, it is our duty to help you find the right places and the healthy places to start. And we just want to be that phone call.
Awesome. Well said. Thank you so much.